let's get started today. I want to welcome all of the guests, and I have to acknowledge a few of our very special guests that are here. First, Her Royal Highness Princess Marie of Denmark, who is attending today in her capacity as honorary board member of the Veterans Coalition International. And you'll hear a few short remarks from her later today. Mrs. Christine Grady, wife of Admiral Christopher Grady. That's got to be fun, two Chris's in the same house. He is the vice chairman of the Joint Chiefs of Staff. And Chris, thank you again, dear friend, for being here. Brigadier General Deidre Tahan, director of the National Capital Region for the Defense Health Agency. Ambassador Lisa Gable, who is a member of our Memorial's Distinguished Campaign Advisory Committee. Thank you, Lisa. Our Military Women's Memorial Board Chair, Major General Jan Edmonds, U.S. Army retired. She's not in the front row at this point because she's in the back row waving at me. Hi, Jan. Military Women's Memorial Board member, United States Air Force retired Brigadier General Barbara Goodwin. She is a former chief of the Air Force Nurse Corps. Our Serving in Strength program would not be possible without our amazing corporate and community partners who are fortunate to have with us here today. From Tri-West, Donna Hoffmeyer. From Maximus, Karen Sinnebalk. WPS Health Solutions, Dr. Joelle Velakis. Sorry, that name. Am I close? Oh, perfect. She's one of our panelists this afternoon, too, and you'll get to hear that name all over again. AARP, Joanne Webb. Optum Serve is here in spirit. I don't think I see an Optum Serve rep in the house, but we're delighted to have their support and sponsorship. And Humana, Alex Ware. Huge thanks also to our community partner for this event, Moral Compass Federation, or MCF for short. They are a powerhouse in the veteran space. Timothy Tito Torres and Amy Martin are both here today representing MCF. They lead the mission and vision to empower veterans communities to address moral injury through education, advocacy, and action. They launched MCF's Health Initiative program as they saw a great need across the military veteran community, which became acute during the evacuation and resettlement of our Afghan partners in 2021. Veterans were burning out and failing to address their own mental health challenges as they sought to help others. Quick aside, I will tell you during that time, I cried more than once in the shower myself. And did not seek any kind of support. MCF found a great desire from many veteran-led organizations to join together to create a network that provides a wide variety of resources from traditional and non-traditional mental health and brain health support. The Moral Compass Federation and the Military Women's Memorial, along with all of our corporate sponsors, believe that working to build a system of care, an ecosystem of VA care, private care, and veteran health-focused nonprofits, all working together in a public-private partnership continuum will ensure that veterans have access to the best care and support for brain health, mental health, and wellness and beyond. I did not serve as a registered nurse. I am a military intelligence soldier for 37 years. But when I left active duty after 4 years, I went back to school and did become a nurse. So having been a medical professional myself for nearly 40 years, I'm immensely proud to see the Military Women's Memorial step into the limelight as a convening space and bring together thought leaders to tackle some of our most important issues, from health and wellness to women, peace, and security. So we're going to kick this afternoon off by asking the former Secretary of Veterans Affairs, David Shulkin, and Jenny Shulkin, same last name, and we'll explain shortly, to come to the stage and join me as we have an opening fireside chat.
Yeah, that's fine.
a rose between two thorns. Maybe. So I've had the honor of working with Secretary Shulkin for a few years with an organization called Policy Vets. Let's start there. Talk about Policy Vets and what then launched both of you into what you're doing now with your own organization.
Well, first of all, thank you for putting this together, Phyllis, and it's an amazing group of people that hopefully will get a chance to interact throughout the day. When, I served as a political appointee, first for President Obama and then for President Trump. And when you're a political appointee and your time comes to an end, mine came quickly with a tweet from President Trump. I didn't know you could be fired by tweet, but I learned that's the case. All that experience that you have, everything, one day you're at the very top of the knowledge of how this system works and you learned all these lessons, and then the next day that knowledge just disappears. And I really felt that my story about having gone to serve and learned so much and learned lessons was experienced by thousands of political appointees and others that aren't political appointees that served and then went back into the private sector the way that it's supposed to be, right? You serve government and you go back and you be a citizen. So I wanted to find a way that knowledge could live on. Now, in my case, I decided to write a book about that for future leaders of the VA, that they could see, what I was thinking and what my vision for the VA was. But what Policy Vets is a place where there's a collection of these knowledgeable people that can be helpful in contributing to current legislation and helping people through policy issues and helping current government leaders to learn from their experience.
So one thing I failed to say, but I think you have it in all of the literature that you're probably sitting on or you've put under your chair. Let's talk a little bit about your educational background to set the scene of why you qualified to be talking and leading this effort with both Policy Vets and now your new organization.
Well, I'm a physician. I'm a general internist, primary care doctor, but I've spent my career mostly running large health systems. So I've been the CEO of a number of some of the largest private healthcare systems in the country, mostly in the Northeast. And I was the CEO of a health system in New Jersey, and it was during the time of the wait time crisis for veterans, and it was very concerning to most of us as citizens. And I used to read the stories and say, wow, I wish there was something I could do. And then one day President Obama called me and said, there is something you could do. We could use your help. And I said, of course, glad to help.
So let's move on now. Talk a little bit about how you came to join your dad on this process, this program, and why you think it's like a calling for you now, it seems.
Well, so unlike my father, who actually is trained as a medical physician, I am not, even though I'm currently running alongside my father a medical organization that's focused on people dealing with chronic pain. I, on the other hand, am trained as a lawyer. I went to Harvard Law School. I served as a federal law clerk in New York and then a Manhattan district attorney and a big law criminal defense lawyer. But at the same time as I was finishing college, going through law school, starting my career as a lawyer, I've had a very complex chronic pain syndrome that affects multiple parts of my body. I've traveled the country looking for relief. I've tried and failed dozens and dozens of medications, interventions, treatments. It's really been unbelievable. So I come to a leadership position at our company that is about 3 years old now this month. It's called Override Health, designed to help people with chronic pain as a leader with lived experience, not with medical or official training. And I think that in the veteran community, from what I've observed, being my father's daughter as he served under Obama and under Trump, is that we've seen so many of our nation's heroes become leaders of various organizations that are helping with suicide and mental health and substance use and loneliness, and they're doing it from lived experience. So I connect on that level.
So let's pull that thread a little bit more. So here we are, we're talking about brain and mental health, and you're talking about chronic pain. We know there's a connection, obviously. Talk a little bit about the mental health that issues that you might have had because of that chronic pain, and you're going across the country asking for somebody to please.
Yeah. So first of all, there are probably several people in this room that experience some form of chronic pain, because 1 in 5 Americans do. In the veteran population, it's actually higher. It's somewhere between 30 to 50%. And what we know about people living with chronic pain is that almost half of them have a mental health condition associated. And what we know from the science is that they really have an interplay with each other. So sometimes mental conditions can lead to physical symptoms. Oftentimes it's the reverse. Living with chronic physical symptoms is quite stressful. It leads to anxiety and depression. But that from a neuroscience perspective, we know that they affect each other and form sort of a cycle. So we have to treat them together. It's not enough just to target one or the other when the other one is so important.
So it sounds like you're talking holistic health. What the heck? Dr. Shulkin, really? Is that something you guys are looking at doing? Treating the whole person?
Well, here's the thing. Going back to what you asked me about, when President Obama called me during the time that the VA was in crisis and said, "We need your help," I said, "Mr. President, look, of course I want to help, but you're asking the wrong person. I don't know anything about the VA. I was a medical student resident there, but that was 100 years ago. You have thousands of people who know about the VA. You should be asking them." And he said, "No, that's the reason I'm asking you, because I don't want somebody from inside the system. I want somebody from the private sector to show us the right way to run this system." I said, "Yeah, how hard could that be?" So I went to the VA with a little bit of arrogance and said, "I'm going to show them. I'm going to fix this system and show them how to run an efficient system." And when I got there, it was exactly the opposite. I saw in the VA a model of care that we couldn't do in the private sector, because we have these things called insurance companies and third-party payers that say, "No, you can't do integrated care. We're not going to pay for multidisciplinary care. We're going to pay for injections and procedures and devices, and we're going to pay that well. But if you want to spend time with patients, we don't pay for that very well," and so nobody does it. In the VA, where we didn't have to worry about getting paid and billing, we could actually focus on what people needed, the veterans needed. And so what I saw in the VA was interdisciplinary care, where behavioral health was delivered in the primary care setting, where teams work together. And guess what? The results were much better. And so what I learned, instead of trying to change the VA, I now spend my time telling my private sector colleagues, this is the way we should practice, that you need to practice in teams, that you need to integrate behavioral and physical health. So now, while I learned that as a professional, and I believe that's the best way to deliver care, I'm also Jenny's father. And when we tried to get that type of care in the private sector, guess what? You can't find it very easily. You know, pain doctors practice doing their injections and procedures. Psychologists practice doing their psychology. Physical therapists do their things. Chiropractors, integrative. Nobody talks to each other. They all don't ever get together and say, what does this patient need? How do you do holistic care? So that's why we decided, well, if it's not there, we need to build this company, because there are too many Americans who can't get their care at the National Intrepid Center, which is an amazing place, and at the VA, which does incredible work. But regular Americans can't find that type of care very easily. So we went out to build that.
And even many veterans can't get that type of care if they live too far from a facility that's offering this type of interdisciplinary care. So what we do at Override Health is we have chronic pain specialists across pain medicine, physical therapy, psychology, and coaching who are working individually with patients through one-on-one video visits. It is all virtual, and they're also working together as a team. Then we've built a whole mobile app with pain neuroscience education built into it to help the patient become more of a self-manager of their own condition rather than depending on a provider to fix them. All sorts of other tools like goal setting, a meditation library, direct messaging with your providers that allows the patient to engage in their care in between their actual video visits with their providers. And so this is available to people like me who haven't served and don't have the VA as a resource, but also to veterans as part of TriWest and Optum Serve, because we know that while the VA is doing so many things right for so many veterans, there are still veterans who can't access so much of what the VA does have to offer.
So Secretary Shulkin, we were talking just before this about an announcement that was made by the VA this morning. What are your thoughts about that? In that up to 3 visits, no copay for mental health?
You know, one of the great things about not being in office is I get to speak my mind. You know, not many repercussions to me anymore. So this will not surprise people in this room. That's a sophisticated audience, particularly our veteran service organizations and others that spend their time thinking about this. The government and the VA is so large, they send out conflicting policies and messages. And so the VA does many, many things terrific, and I am a strong supporter of a strong national VA. I am not in favor of privatizing it, but I'm in favor of strengthening it. On the other hand, there are policies and procedures being put out today that are limiting access to care to our veterans. So you're seeing both good and bad. So today's announcement was a good one, which basically said that if you seek behavioral health care, either in the VA or in the community care network, your first 3 visits have no copay, which is a good policy. It improves access. On the other hand, what we're seeing right now is that the VA's in a huge budgetary crisis. They hired 71,000 people last year. They probably should have hired 40,000. So they're behind by about $6 billion, which even in the VA is real money. And so what they're doing is they're restricting access to care, particularly through the community care networks. And, you know, I know what it means to have to run the VA, so I'm not trying to throw darts at people, but our veterans need access to care, not restriction to care. And so at the same time, you're seeing good and bad. But I am concerned, and we've seen a number of members of Congress come out just recently publicly saying that veterans are being denied access to behavioral health care because of this pullback of the community care network. And I'm concerned about that.
So I think what we've all said previously is this is a whole of nation response. We owe this to our servicemen and women, our veterans, right?
Sure.
And so I know for a time, several years back, there was a thing where we were asking mental health providers to just, you know, accept a couple of patients pro bono, if you will, kind of a thing.
Give an hour.
Yeah, give an
Yeah,
hour, exactly. But with Override, how many folks have you guys sort of circled the wagons around and are providing at least, I mean, what do you do when somebody comes to you and says, I really do need the help? What do you do next after they reach out to you?
Well, we're pretty unique in that respect. You know, very quickly when you're a patient with chronic pain, you exhaust the options that your insurance company covers or, you know, maybe that the VA covers. You exhaust the pain doctor visits, the pills that they prescribe. And then you find yourself in a world where you can say, I give up and I just have to live with this. I guess there's nothing left to do. Or you can say, I'm going to spend every last dime that I have, maybe fundraise from a church fish fry, and I'm going to go after all of these other things that exist outside of the covered insurance world. And so living with chronic pain is expensive. There are providers and practices taking advantage of patients every single day because living with pain is terrible and hope is the best thing. At Override, we actually take insurance, and we are one of the very, very few people, especially that's offering the mental health services connected to chronic pain that accept insurance. In fact, I don't know a single other place that does. And I live in this space and as a patient and as a professional, and I know who the competitors are. So we take Medicaid. The vast majority of our patients are Medicaid patients. We are often giving discounted prices to people whose insurance we don't take but really need the help. And a lot of that comes from our lived experience of just knowing how much it hurts to suffer and that it is so hard to access this care.
And you know, I will say getting access to care, particularly the behavioral health aspects of pain, is really challenging. And I don't know if people, I mean, it's a pretty sophisticated group here, but I think everybody knows the issue with veteran suicides, which when I was secretary, I made that our single top priority. And fortunately, every secretary since has kept that as the VA's top priority. Unfortunately, last year, it went up 11.6%. If you take a look at the report that VA does, which is an excellent report, and you look at the number one symptom of people who have taken their lives, it's chronic pain. Yet, if you try to access, even in the VA, and I have to thank President Trump for this, when I went to President Trump and I said, I want to publish our wait times publicly, put them on the internet, he said, we should do it. And we went and we did it within the first 2 weeks he was in office. If you look today and you look at access to pain in the VA, lots of our VA medical centers, 150 days to get an appointment, 90 days to get an appointment. So these people are sitting there suffering without the ability even to access VA caregivers because there's a shortage of pain treatment. And so we are available through TriWest or through Optum Serve, and the issue is we need to get people access to care.
How hard is it, Dad, to watch your daughter suffer?
Listen, there's nothing more frustrating than knowing that we're fortunate in that because of being a doctor and my connections, we can go anywhere in the country, but still can't get things that necessarily help. So this is a really challenging issue for many people, and that's why many people feel very hopeless about it. And so and that's the issue with, veteran suicide. There's been lots of effort expended, lots of money, lots of people working on this, but yet we're going in the wrong direction. So, but when you have tough problems, you have to just continue to stick at it to find the solutions.
How many patients do you have now that you're providing care for?
We published a press release last month that we had provided care for 1,000 patients now, and we have a lot more growth to do. We're currently in 9 states and would like to continue expanding. So, but we're getting really good results. About 80% of our patients report improved pain management after working with us for 3 months. And a lot of people say things like, I've had pain for a decade, but nobody's ever approached it this way. Or, for the first time in a long time, I really trust my care team. So we've designed a very intentional program to meet patients who have struggled for a long time where they are.
I can't imagine, what some of these folks, it's like last ditch effort. We've tried everything else. And we're sitting here looking at a dad that is a physician, that has been the Secretary of Veterans Affairs, a daughter that's a Harvard law lawyer, and they're having trouble. Is that not fairly clear cut on what the situation is for the rest of us in this country?
Yeah.
But for you to see this, and I had a lot of people when I said I wanted to call this session, this seminar, Brain and Mental Health. A lot of people were like, why the brain? And I'm like, well, let's talk about the brain quickly here, about the difference. And again, diet and mental health are not negative terms. You know, whatever you consume is your diet. But if you tell somebody to talk about your diet, they think you got to lose weight. And if you talk about mental health, it has a negative moniker to it, and it really shouldn't. There can be really good, very strong and resilient mental health, and there can be times when we're challenged. So the brain itself, let's talk a little bit quickly about why you think the brain needs to be part of this conversation.
Yeah, well, so I'll explain it as a layperson. Essentially, learning to be in chronic pain is a little bit like learning to ride a bike. So at first, when you're learning to ride a bike, you stumble, you fall, you can't get the hang of it. But after enough practice, after enough repetition, it gets to the point where you get so good at riding a bike that you actually can't forget how to ride a bike. Unfortunately, the same is true with chronic pain. Regardless of how it was caused, whether it was random, an illness, an injury, if you spend a sustained period in chronic pain, your brain and your nervous system actually get so good at learning how to be in that pain that they recreate it on autopilot. It's kind of like a broken record error loop. And that's why this is such a tough problem to break, because it's actually ingrained in the nervous system at a certain point. So even if it's someone's arm that's hurting them, you know, the reason why they may not be getting relief from the surgery or from the countless injections into their arm is because we need to treat this as more than just a body part problem, but as a nervous system problem, which encompasses mental health. You know, it's sometimes difficult to know whether the right terms are neurological, psychological, social, you know, and that is where this term biopsychosocial comes from, because we're basically saying we don't really know what's going on, but it's probably everything when it comes to nervous system dysfunction, which at its core is what chronic pain is.
And the classic example for those who say this can't be this has to be in the peripheral body part, not in the central part, of course, is phantom pain, where you have an amputation of your arm, yet your brain saying, your arm hurts. And you know that has to be the central nervous system because you no longer have an arm.
Right, and it's not psychological per
Right.
se.
Right. And so an approach, what the science is showing now is that chronic pain, as opposed to acute pain, needs to have a strong neuroscience-based component.
So I want to give you guys a moment to, what's your final thoughts here on why you think what you do with Override and why it's so imperative, particularly in the military and veteran spaces, that we step up and answer this urgent need?
Well, look, I'll start and I'll say, you know, Jenny mentioned that 80% of our patients are showing improvement. If this were a new drug coming out, right, this would be labeled miraculous, you know, miracle drug, a GLP-1 drug for losing weight. But what this really is it's saying by getting people who focus on physical health and behavioral health to work together, you can get miraculous results. I wish it was more complicated than that, but this ability to integrate physical and mental health and work in teams and interdisciplinary formats is really the way that we need to go in this country.
Well, and I'll say the opposite, as I often do. This is not a simple problem. It's not a simple solution. I mean, if anything, this is one of the toughest problems that there is. You know, we're talking about chronic pain, you know, often relentless chronic pain, substance use disorder, you know, Americans misuse opioids for the most common reason being chronic pain, and then substance use disorder and chronic pain both being linked to suicide, issues that we see very, very often in the veteran community and outside of it. So, you know, I would just say the theme of what we've been building is to not go after the low-hanging fruit, you know, to not go after the easy problems, because somebody has to deal with the hard problems. And that's something that a lot of us in this room can relate to. So for those of us that are working on tough problems, let's keep fighting.
Let's keep fighting. Thank you both so very much. I appreciate it. We're doing a chair thing, so pay attention to me while they do things on the side. Thank you again. I think that really illuminating to me that you have a former cabinet member and a physician and a Harvard lawyer, and they're struggling to find the answers. It's very clear to me what we must now do. And without further ado, I'd like to introduce a dear friend of mine. We served together in the Pentagon, and I'm so proud to have Dr. Kelly Brown, the Vice Chair, Board of Directors for Allied Forces Foundation with us today. She is a retired Army combat veteran and is highly respected leader with nearly 30 years of success managing high-performing joint teams and international governmental teams. She's a Black Hawk pilot. It's not in here, but I got to put it in. She's a graduate of West Point, a strategist and a forces manager. She has extensive experience across multiple disciplines, including continuity of government, national contingency operations, homeland security, emergency management, disaster response, policy development, and aviation operations. And if you get a chance during reception, ask her to explain how that little short woman clear that she could reach all of the equipment in the cockpit of a Black Hawk to fly it. They tested her on that. And now she serves as a nationally registered emergency medical technician, an EMT, and a lieutenant in the Falls Church, Virginia Volunteer Fire Department. Kelly, without further ado, please join us up here.
I just love Phyllis. She's the most amazing person. It was such a pleasure to meet her back in 2015, and my life has been fuller and richer because of it. So Phyllis, thank you for having me. It's a pleasure and an honor to be here. I am super excited about our panel, and I have a few notes because I want to make sure I get our distinguished panel correct. So as I introduce them, if you will just please come on up. And then as our second panel today is going to focus on traumatic brain injury, what we're going to focus this panel's discussion on are the practical aspects of mental health for our women veterans, where select medical organizations stand in their advancement of mental health services for women, and treatment innovations that are changing women veteran experiences. So let's meet our distinguished panel. First, we have Naomi Mathis. So if you'd please come up. Naomi is an Air Force veteran. She is the Assistant National Legislative Director for Disabled American Veterans. DAV was created in 1920 by World War I veterans to help disabled veterans. Today, DAV empowers all veterans to live high-quality lives with respect and dignity. In addition to providing free of charge services such as transition, homelessness, and disaster relief assistance, DAV also conducts extensive research surrounding veterans' issues. In their most recent study, Women Veterans, The Journey to Mental Wellness, speaks directly to the topics that we're going to discuss today. And if you haven't already read it, it came out just recently, I highly encourage you to do so. So our next panelist is Duran Young. Duran, if you'll please join us on stage. Duran, also an Air Force veteran and licensed clinical social worker, is the founder of Black Therapists Rock. BTR was established in 2016 and is a nonprofit organization that mobilizes over 30,000 mental health professionals committed to decreasing the stigma and barriers to psychological and social well-being among marginalized communities. Recognizing that patient needs differ, BTR has partnered with innovative organizations offering unique techniques to address mental health trauma. And we're going to talk about some of those. There's some pretty exciting stuff going on. Our third panelist is Dr. Joelle Vlahakis. Doctor, if you come up, please. She is a board-certified internist like Dr. Shulkin. She is the Contractor Medical Director at Wisconsin Physicians Service, WPS Health Solutions. WPS was founded in 1946 to address the affordable health insurance needs of the 300,000 World War II veterans, 13,000 of which were wounded, returning to Wisconsin following the war. Today, WPS Health Services is a leading not-for-profit health insurer and administrator of U.S. government services, including TRICARE. Dr. Vlahakis is working on Innovation's Challenge Project to improve chronic care management and depression screening. And finally, but certainly not least, our last panelist is Lisa Peterson. Lisa is a certified rehabilitation counselor and licensed clinical mental health counselor. She is the Chief Innovation Officer at Operation Relief Fund, ORF. Established in 2022, ORF's mission is to bring best-in-class wellness treatment and services to shadow warriors struggling with operator syndrome, commonly referred as PTS. A shadow warrior is a member or veteran of the special operations and intelligence communities. To date, ORF has funded 435 warrior health and recovery journeys and is at the forefront of innovative techniques, and we will discuss those also here in a moment. So just have a warm welcome for our panelists. They're very impressive. Okay, so let's get into the meat of it. So I also happen to be a veteran healthcare giver. My mom was a Marine in the Vietnam era, and so I've been a client, along with my mom, of the VA system for the last 30 years. And while I can attest that certainly the VA healthcare system has improved greatly, especially in the last 10 years, there's still a way to go. As Dr. Shulkin mentioned, there's access care to the care for medical appointments. There's issues for that. But also, and especially in the DA report, it acknowledges that the lack of recognition for women's service, isolation after separation from military service, poor social support, and unique factors all contribute to the challenges and barriers that women veterans face when they leave military service. And that transition from service to the civilian network can cause a lot of challenges with their physical recovery and mental health. So Naomi, you have a very interesting story. And can you please tell us about your personal journey and the struggles you faced and how you became a part of DAV?
Absolutely. And thank you for having me. So I served from 2000 to 2007. I was in the Air Force, but I was air battle management. And what that means is we were the Air Force's little Army unit. We were on the ground, forward deployed with our ground radar to control the planes that were in the fight, tell them where their targets were and all of that. So we played a lot of war games, but ultimately we ended up in Iraq in 2003. That was my third deployment. And we came under several attacks, and unfortunately we did lose someone on our convoy. And when I got back home, it was, first of all, the reception obviously was different. You know, we were, thank you for your service, welcome home, and all of that, something that the previous era veterans did not get, particularly Vietnam. And when I got home, I realized that I felt like something was wrong with me, didn't realize, exactly what was going on. And so I reached out, sought help, and was getting, I had chronic pain, dealt with chronic pain as well. And so I was on several medications, did not realize the implications of that, of being on so many. I was on, psychiatric medications, pain medications. Oh, by the way, I had just had a baby. And so now I'm dealing with hormones and all of these different things. And one day my little kid was on the bed and I started having really bad thoughts. Thoughts that I should not have been having. And so I did seek help and I did get help. I was still active duty at the time. Long story short, the Air Force said, thanks for playing, and retired me off of active duty. And I had someone tell me about, DAV as as employment, and I said, DAV, the old guys with the hats with the pins on them. Why would I work for that? And so, um, come to find out, there's this organization on a national level that has over 1 million members of all different eras. And I found camaraderie because that is something that you do lose. That is honestly, the most significant thing that you realize. Like my brothers and sisters, they're gone. I don't have that anymore. And so, I got that camaraderie back. I got, and was able to help get me through. And so I also want to point out that, as Secretary Shulkin mentioned, the annual suicide report that comes out, um, you know, it's incredible to realize that there are people that are really paying attention to these because last year the numbers did increase. But I just want to say, we're talking about how I got with DAV. DAV is, one of the oldest veteran service organizations, and really are leaning forward on a lot of this. And I know we'll get into that later, but I just kind of wanted to throw that out there.
Well, that's great. So let's get into it. So your your transition though is maybe a little bit more tumultuous than you've shared with us so far as well. But I understand it was rough going from the military transitioning over, especially with all your health needs and maybe some lack of access or awareness of services. So talk to us about what DAV is doing to make that journey smoother for today's veterans.
So we have over 300 benefits advocates that are out there that are embedded in VA regional offices to help veterans get their benefits and services that they've earned through their military service. And that is a lot of times their initial introduction into, oh, there's other things for me out there. And so we try to kind of be a one-stop shop. But that's just one of the things, as far as benefits advocates, and help them file their claim at VA for compensation. But the other thing we're doing is things like our Women Veterans Report. By the way, if everyone should have gotten a handout when they walked in the door, and that kind of has, our highlighted points. But the full report is on womenveterans.org. Just type in womenveterans.org and you'll get all of the information, including the full report there. But so that, another thing that we're looking at is we're trying to work with legislation, policy, work with VA. Every day we're working with VA, we're working with the Hill on how we can advance policy so that veterans better have access, employment. Transportation, trying to get veterans. Can you imagine being a rural veteran and there's 100 miles between you and the nearest anything, but definitely the nearest doctor, and you can't get to that appointment because maybe gas price is too high, or maybe, you just can't physically get there. So that's one of the things that we also offer too is our transportation network, which is very, very good. So there's a lot of things that DAV is offering to veterans to try to make it so that they have better access as well to healthcare.
That's fantastic. So one of the challenges, and I know Dr. Shulkin mentioned this as well, but or at least he's alluded to it before, is that once you get access, once you have an organization like DAV who helps you get that access, then often your first stop is with a physician. Before you maybe see a mental health expert or a therapist, usually you have to go through your primary care to find them first. At least that's a lot of folks' experiences. So, Dr. Vlachis, can you talk to us a little bit about, are there things that physicians can do to help their patients get to that state, because a lot of them are reluctant or afraid to even say anything. We never want to report those type of things. I don't care what they tell you, like, oh, it's all going to be okay. You're still reluctant to do that. So what can the doctors do? And then on as well as that, what can the patients sort of do to help themselves, help their doctor, help them? you know.
Right. So, yes, I'm an internist and a pediatrician by training, and then worked through my career in different environments, hospital, rural, et cetera. And then the last gig I had was in hospice and palliative medicine, where I learned the value of team. So that was a paradigm shift for me in terms of my own thinking. And I think so much of the time, much of my training was spent on the mechanics of learning how to care for patients, how to do the work. And it is an extraordinary job. And it takes a long time to learn those things. But I think what I appreciate the most now, we have all this technology, and it's incredible what we can do. But the thing that I always come back to is that sacred space between patient and physician. When you're developing that communal space between each other. And there's a lot of forces outside of that that are intrusive and interrupt that and can be external. Stressors on both physician and patient alike. But I think the first thing we have to teach ourselves as physicians is to simply ask. One of the things I've learned in our depression screening project is that it doesn't have to be fancy to simply ask and figure out if someone needs further services. Some of our tried and true tests are two questions to get at how are you? So it doesn't have to be fancy. And I really love that. I love that it gets to the essence of what it means to be in that relationship. And I think that is in part the key. Sometimes you don't have a whole lot of time to build rapport with a patient that you've just met as a physician. And I'd love to be able to say that it is easy to do that, but it's not. But I think if we understand and we come to that encounter, understanding that there are external stressors on both of us, and what can we do to insulate ourselves, even just for a few moments, so it can just be you and me. I think it really comes down to very basic things.
So mental health has come so much more to the forefront. At least publicly, we talk about it more now than we ever did before. It's losing that stigma that it used to have. But and as we go forward with that, talk to us a little bit about kind of as physicians, what do you wish maybe you had known when you were starting out, or that maybe you had wished you had done differently, and that you would encourage, physicians to do today?
So much. I think what I'm learning now is that mental health care is simply health care. It is part of the service that we render. It is holistic. It has to be. I don't come into the cardiologist with just my heart, right? I come in as a full person with a family behind me and a community behind that. So it has to involve all of those connectedness. I really wish I understood that. I spent a lot of my time, of course, as a baby doctor, trying to learn things and be impressive to my attending physicians when they ask me questions. And even as a fellow physician, trying to make sure I'm useful to the team, to my colleagues. But I really have had to learn over time that the thing that brought me to medicine in the first place, that desire to be in the presence, that ability to have the privilege of being in that space, that's the thing that carries me now. It's not the brain that I walk around with. I used to tease my nurses that you guys just think I'm a brain with feet and I could just walk around. It's the heart and soul of it. And that actually has value. And I unlearned that through my early training, and then I had to learn it again.
So let me ask you like a practical question from a patient side. So sometimes patients click and they're fabulously get along with their docs and life is great. But then we have those experiences where we just do not click with our physician for whatever reason that is, whether it's personality, maybe there's a trust issue, what have you. But folks are often reluctant or scared to go against their physician, to ask for a new physician or a second opinion. So what kind of advice can you give to us from a patient perspective of what should we do when we're with a doc and that doc just really isn't our doc? What do we do?
So I don't come from a family of physicians. I'm actually kind of the black sheep of my family. They're all teachers. But what I tell them is you want to go to a doctor that you'd have lunch with. Now, most doctors don't have time to have lunch, but you could, and you'd enjoy yourself, and it would be a time of sharing. I think sometimes as patients, we're very impatient. We want that relationship to form up so quickly, and sometimes it has to when we're in urgent situations, absolutely. But I think sometimes we don't have patience with that opportunity to get to know each other. It happens sometimes a little slowly, and it does take some time to build up that trust, and that's okay. But you should basically like them, and it's okay not to.
Yeah, I will tell you from personal experience in the military healthcare system. I've had doctors that I loved and they were amazing, and then I've come across some that were not working for me. It was a challenge, and it's hard to get those appointments. Like Dr. Shulkin mentioned, you wait 60, 90, 100 days to get in there just to see someone. Then you finally see someone and you're like, oh my word, I finally see someone, but I'm not getting what I need out of it. And I've either sometimes gone with the flow, because sometimes you just got to get to the next point, or every now and then, if I've had the time, I've been lucky enough to get back in the system, wait my 60, 90 days, but that was better to get someone that I clicked with and then got some of the support and healthcare that I needed. So I don't think there's a one-stop good necessarily answer. Maybe we're working on that as a system in general, but it's good too if you know that your doc isn't kind of provide for you what you need.
I think your primary care doctor should be someone that you dig. Yeah. I do, because they're the ones that are going to lead you to so many others. There may be times when you're going to go to a specialist and you really just need that brain to tell you what to do next or to give them the thoughts. But it's that primary care doc that you should be able to connect with. So I kind of agree with you on that.
So love your primary care doc, and they should love you. Okay, perfect. So there's a lot of great statistics in this, in the DAV report that came out, and I'm just sort of going to switch gears a little bit because in the report, it did, we all know that after you experience some type of trauma or a very traumatic event, there's a lot of different feelings and emotions that go along with that. It can be shame, it can be a feeling of isolation, or disbelief, but it's how folks deal with that and how they deal with that trauma and how you get past that that is very significant. The DAV report also talked a lot about military sexual trauma, and it's associated with an increased risk of lifetime suicidal ideation, suicide attempts, and suicide mortality in both men and women. So it's not just a women's issue. It's an everyone's issue. History of family trauma and other sexual trauma is also a risk factor for suicide. Substance use disorder, heightened suicide risks for both men and women. And the risk of suicide death among women veterans with active substance use disorders is more than twice of that it is for men. So some staggering statistics for how all these factors affect women in our future. And so, Duran, you have a really compelling story that relates back to trauma in its various forms. And if you would please share for us your story and how that story brought you to where you are today, please.
Hi, yes, so my name is Duran. Okay, yeah, so my name is Duran Young. I am a retired Air Force mental health officer. I actually started off enlisted as an E1. I came in right after high school as early as I could, right as I turned 18. And the interesting thing for me as I look back on my journey is kind of my motivations and my intentions behind even joining the Air Force. At the time, I was 18 years old. I was actually sleeping in my car, in a Walmart parking lot. And I had wrote my recruiter 3 years earlier saying, I really want to be in the Air Force. I'm from Wichita Falls, Texas, where we have Shepherd Air Force Base. And I had gotten to know other airmen who, escaped poverty, escaped trauma through the military. And I'd always been told I was smart, so I knew I could go to college. But I also knew that I needed the money to go. And when you're homeless, the idea of college seems like a dream. And so, growing up in my home and in my family, my mother struggled with untreated mental health issues, specifically bipolar symptoms of bipolar disorder. And I watched her suffer, and I now realize that the empathic part of me really related and connected to her suffering. I didn't know that there were names for it. I didn't understand what was happening to her, but I knew that she was in pain. She was in emotional and psychological pain. And I looked out my window in our neighborhood and I saw a whole community of people that looked like me with that same emotional suffering. And so I just thought, there has to be something that someone can do. I was very bright as a kid, as I said, and I believed in authority figures. I really believed that there were people out there that cared about other people so much that they wanted to make a career out of it. And I one day wanted to be one of those folks. So I decided that I would be a helper for a living whenever I got to become an adult. So I joined the Air Force as E1, and I'm really fortunate because when you join and you say, I'm willing to do anything, you usually get a job you don't like. I feel really privileged because I got to be a medical administrative technician, meaning that I got to work in different areas of the hospital, from insurance to medical records to, specialty care, working in the dermatology clinic, working in primary care, working in internal medicine, working in the ER. So I got to see kind of how different systems work within a system. And I became fascinated with that. I really wanted to understand what worked and what didn't from a user perspective, but also from a person on the team perspective, supporting doctors, supporting nurses, and helping to control the flow of information. That's why I realized most of the breakdowns happen in the communication. So I got my first degree in social psychology. I wanted to understand how groups of people, really relate to each other and understand each other and feel and connect with one another. I went on and I was able to do the Air Force Educational Leave of Absence. I got to spend 2 years at University of Texas. Within that 2 years, I got to go to West Africa and study generational trauma there, where I really became even more passionate about systems and culture and mental health and all together, really just understanding how to help people, help a lot of people with just simple policies and procedures. So got my master's degree from University of Texas after getting a first master's degree in public administration because, again, I really wanted to understand organizational behavior as well. And I thought that all of this education and experience would lead me to the VA because that's everybody's dream when they're active duty, right? You want to retire from the military and go work for the VA. So I actually got to do an internship as a social work student at the VA clinic in Austin, Texas, and decided very quickly that that was something I could never do. I was working with the homeless veteran outreach program, and it was just heartbreaking to me that we couldn't even provide a blanket at times for veterans some who were airborne and had been jumping out of planes for a living, and of course their spine and everything in their body hurts, but we can't give them a blanket. So that was something that really stayed with me and made me feel like I wanted to help the system, but maybe I might have to operate outside of the system. So I started thinking of ways that I could, touch lots of people within a systemic approach. And as I started approaching retirement, at the time, like I said, I got commissioned and was primarily working as a therapist for active duty members and their families. And I started noticing this trend of generational trauma amongst the veterans, even or the active duty members. People who were struggling with addiction or struggling with depression, struggling with even coming in and saying, "I need help." Really. And so I wonder, like, how far back does this go in our culture, in our country? This seems like a national problem. If we have the best of the best in the military and they're struggling with these things, I think a lot of families in our culture and in our country are struggling with dysfunctional families. So I really started to study that from a systemic approach. And of course, as a social worker, I was really kind of rewarded for my systems thinking. but yeah, I really got to understand patterns and themes and how things were connected. And when I retired, I decided, I want to bring this to some of the people that I saw suffering when I was a little girl. So I created this nonprofit called Black Therapists Rock while I was on active duty in Aviano Air Base in Italy, all the way in Italy. Decided to start this Facebook group, and I thought, if I get a couple of hundred therapists out, we can go out to communities and educate them about trauma, because you say trauma and people don't understand what you mean. They don't think of poverty. They don't think of, family dysfunction. They think of the military most of the time. So I wanted to go out to communities that might not come into a therapy office, people, that don't have a home, or people who don't have a car, and really take the message and the healing out into the community. So I thought, okay, this is a really grand idea. If I get 100 therapists, maybe we're working with something. And so by the end of that month, we had 10,000 therapists in this Facebook group. And I remember being in my uniform at night and thinking, how the heck am I going to manage this? How am I going to lead this now large organization overnight? I had my own health issues. I had a lot of my own problems that I was struggling with as well. But when we think about things that we lose when we're leaving the military in transition, for me, I feel like I lost a sense of belonging. Kind of going back to what you were saying about always having a team or people that you knew had your back. The other thing that I kind of struggled with on my transition was a sense of security. Like I said, when I joined, I was homeless. And so everything in my nervous system was saying, if you get out of the military, you're going to be homeless. If you get out of the military, you're going to be homeless. So I was completely terrified. My health was failing. I had a thyroid disorder that I had kind of ignored for 10 years, because another thing we know in the military is that if you're not well, you're not going to be on active duty. So as I was writing MEBs for other people, I knew that, if my health started to decline, I might lose my financial security. So I was willing to jeopardize my health just to continue to have a roof over my head, because that's how trauma was deeply ingrained in my body. So as I transitioned, I was able to find a trauma day center here in DC that I was actually, kind of transitioned to through the Wounded Warrior program over at Walter Reed. And it was one of the most profound experiences for me, because I got to get to the root of my trauma. And as a trauma therapist in the military, that wasn't something that I was taught to do. The analogy that I tell people is that we were taught to put a Band-Aid over a bullet wound. I was told that I worked for the Air Force, not the client or not the patient, and that my job was to make sure that they could deploy. So now, transitioning my own health and my own care and well-being, I had to really become my own advocate. I had to learn how to use all the things that I learned in my experience and my education for myself, to be able to say, this is what I need, and if I need help, to be able to know where to go for that. But just as you two said, even though you have a lot of knowledge about a system, doesn't mean it's going to work for you. And that's kind of what my experience was navigating the VA. It was really difficult, continues to be difficult even today. I tell people that I have PTSD, but it no longer has me. I found a lot of resources in community, the American Legion. I'm a member here in Silver Spring, and I've really gotten a lot of camaraderie and sense of belonging from that. Of course, I created this huge organization that I get a lot from, and I get to go to amazing places and talk about the things that I love. So I feel really honored and privileged to share my story with all of you today.
I see a theme in what you're saying about trauma, is that because a lot of times when we think of trauma, we think of a specific instant that happened, right? So if you're in the military, there's a specific combat situation and it happened to you, or a specific, MST situation and it happened to you. But really, trauma is so much more than that. It's so much more complicated. It's so many more events that are all tied together that come to a head at some point, whatever that trigger is for it. So in BTR, you have partnered with a lot of really kind of innovative different organizations that are doing some unique therapy protocols. So can you talk to us a little bit about some of those different protocols and kind of the success that you've had with them?
Yeah, so I will say, because I started the organization on a tech platform, that was our first partner. So we were able to partner with Facebook. I was in a Facebook fellowship for a year, which was really amazing. Got to go to Silicon Valley and see what they do, which is cool. And then I started to partner with people like Brene Brown to tackle the issue of shame, which is rarely discussed in a therapy room and should always be discussed in a therapy room, if you ask me. But got to write a book with her after the murder of George Floyd, specifically for the Black community, which was really amazing. And we're now, recently within the last 5 years, partnering with a lot of psychedelic organizations, psychedelic assisted therapy, which has been profound in my own healing, from things like military sexual trauma, from things like postpartum depression. Here in DC, some people may know that mushroom therapy or psilocybin assisted therapy has been decriminalized, meaning that if you're carrying something that grows out of the ground, you won't be treated like a criminal. Next Tuesday, I'll actually be testifying before the FDA on MDMA assisted therapy. Yeah, yay. To talk about MDMA assisted therapy for generational trauma, specifically racial trauma and things of that nature. So there are profound medicines out there that aren't in alignment with the traditional medical model. And I'm very supportive because when I was in Africa, it didn't take a room to do therapy. You know, we were doing therapy under the tree, and they were telling me about herbs and different natural remedies that were really working for thousands of years. So I've had the honor really to engage in things that are outside of our traditional medical model for my own healing, and I advocate for others to have access to that as well.
Okay, so we're going to switch gears just a little bit. When we think of military in general, but especially when we think of our special operations community, we've all seen like the SEAL Team 6 TV shows and our Green Berets and things like that. And we think of a lot of times our male soldiers that are out there in combat. But as we know, all of our military service positions have been opened up to women and have been now for 7 years or so. It's been a while. So we have women that are out there doing everything that our male counterparts are doing, and they're doing it extremely well. But along with our male counterparts, when they go through those type of special operations and our secret squirrel type operations, you know, they are exposed to things that even our average soldiers aren't exposed to, and they carry traumas with them from that. And so I want to read this one statistic from the DAV report that's not necessarily tied to special operators, but it's tied to women veterans as a whole. And it says that women veterans were found to be 3 times as likely to die by firearm suicide than their civilian counterparts, and more likely to attempt suicide than male veterans. 12% of the female veterans attempted suicide versus 6% of male veterans. And that firearms were used in 51.7% of women veteran suicides, which is a method more than any of the other methods that women veterans attempted suicide combined in total. So that's a staggering statistic. Now we can delve deeper into the whys and things like that, but just on its surface, it's pretty staggering. And so with Lisa specifically, as we delve into the further techniques and the specific techniques that are being used, Operator Relief Fund is doing some amazing things with our special operators to try to prevent this outcome and then other outcomes of PTS. So can you please talk to us about the really unique techniques that OTS is doing that you're involved in?
Yeah, so I came from the suicide prevention, suicide crisis space, and it was all about getting some more time to heal, time to be able to go to a therapy office, time to just be able to try and function. And ORF has worked really hard to work with some of the leading doctors in the community to get more time. So most folks are familiar with the single stellate ganglion block. It's been used in the pain management field for quite some time. It's used as an off-label PTS treatment, and that is what we're funding the treatment for. We partner with providers who are wanting to dig in a little bit deeper to do a dual stellate ganglion block. And so that, in its most simple form, is a pause and a reset of the sympathetic nervous system. So we can reset that anxiety. And that has been an amazing thing to see in the community, to see folks be able to take their first deep breath and not realize they've been holding it for years. And we're talking more than just, I feel like saying PTSD, it's just not enough. We're talking about complex PTSD. To your point and several others, this isn't one event that someone has stored away. This person is wearing, and I always equate it to coats, this person is wearing about 100 jackets, and it takes a while to peel those off and to move in those in daily living. So the providers that we partner with do the dual approach, and that is both sides and at 2 locations. And that allows the individual from our clinical studies at this point to have anywhere from 6 to 9 months plus reduction in PTS symptoms. And so our next step, right, we don't believe in a magic bullet. And as wonderful as the statistics are in the dual block, we are trying to give something with that time. And to everyone's words, it's very complex to navigate, and it's really nice to say you can get help, but where do you get help? Do I Google a provider called an integrative provider or a naturopathic doctor, or who's going to know how to do that? And so the secondary thing that we're providing is laboratory testing that's more alternative, like gut health, heavy metals, hormones. And then with a lot of women, we're seeing a tremendous increase in autoimmune disorders or misdiagnoses of autoimmune disorders. So they may have one, but they're misdiagnosed, and the symptoms were jumbled together, and now they're on 5 prescription medications and they can't function. And so that's the secondary thing. So beyond the special way that we're trying to provide time, we're also providing laboratory testing in an alternative way. And then finally, the kind of big thing that was my initiative when I came onto the program was offering specialized information about providers, so more of a care network. So specialty mental health providers, not just those wonderful evidence-based modalities, but somatic experiencing and polyvagal therapy and more things that are hard to access, and how do you know who's who? And then the other additional thing with the alternative providers is really looking at things to address pain and trauma release. And one thing that we're really advocating to build onto is pelvic floor release for women. We see tremendous amount of our women operators with significant back pain that can't straighten their body anymore and can't function in life. And through, seeing so many providers and having misdiagnoses of, well, you have this disc issue, or you have, fibromyalgia, or all of these different things, especially in the autoimmune category, we're finding that trauma release and pressure point release and acupuncture can relieve pain that's been there for 20 years. And so those are the things that we're making stronger initiatives with, along with the dual stellate ganglion block, because there is no magic pill, but we want to buy people time and access to be able to appreciate and engage in the care.
So most of my time in the military was spent special force adjacent, right? So I was conventional, but we work alongside of our special operators, and we find that all of the really cool stuff, whether it's equipment or techniques or treatment, really starts in our special operations community, and then that kind of trickles down to the rest of us in the conventional forces, and for lots of different reasons. But if you could talk to us a little bit about some of the lessons learned that your organization has come across, especially for our female veterans, because we are a different population. It's just a fact that, men and women are different, and we have different needs and different needs, especially in our medical care. So talk to us a little bit, please, about some of the lessons that you're learning that we hope is going to trickle down to the conventional side.
Yeah, so one thing that several folks have touched on up here today is women need women to speak to, a sacred space, someone that understands their experience. And we found initially that we didn't have that female representative up there to offer that sacred space, to allow a conversation to happen and be honest. So that was a big initiative when we were approached by several women operator nonprofits, is who are we going to talk to about the things that we've never told anybody, and how are you going to get me to the right provider without that? And so that's when we hired women who can serve in that very first phone call role. When someone reaches out to our organization, they get a woman. They get a woman who has been in the military space. They get a woman who has been in the suicide prevention and crisis intervention space. And they get someone who is very trauma informed. And so they know how to have that conversation in a way that they're not prescribing the conversation, but allowing for an understanding. The next thing that I think is really important, and I spoke just very briefly to it, is some of the initiatives that we're recognizing. The dual stellate ganglion block is amazing, and it does give us time. And without the time, you can't engage in the other services. Our minds and our bodies are very, very mysterious, tricky creatures. And when we're spinning out of control, the last thing we're going to do is be organized, attend all of our appointments, and do everything that has been prescribed. And I think we can all say we've been told to do certain things we know we need to do, and we haven't done those because we're just trying to get through day by day. We're surviving at times, even when we're doing well. And so the thing that we've learned is we need to have these providers that we know their names, we know who they are, we know their reputation, and we need to say, you don't need to go see this naturopathic provider or this pelvic floor provider. You need to go see Susan at this clinic. You know, a name, and we're not doing a cold handoff to somebody. And so having someone be able to walk in somewhere, have time bought for them, and then to begin to process through a very long journey of healing that it will be, and it not be a bunch of strangers or mysteries along the way. Even if we can reduce that some, those are the biggest lessons.
Is there a timeline that you have with your patients, or can you stick with them for long periods of time, or are they on a short stay and then they have to move on?
And so we do not have a timeline, and we also do not have a restriction on how many procedures or how many connections you come back with us. We are instituting policy around engaging in those alternative care providers. We often see individuals, as we were speaking about earlier, who I'm fine, I'm good, I'll just get this, and then I'll go right back out there and I'll feel really good for 6 months. And then when all of that falls apart again, I'll come back and get it again. And so some of the policies that we're engaging, and one of our providers does life coaching after, so you can kind of figure out what you want to do with your health and wellness journey and how to line it up. And we're trying to make sure that they engage in those things and they recognize it's okay for you not to be okay, and to take a breath to engage in those things.
So our time is flying, and we literally could talk, I think, for days on this, and all of you are so incredibly interesting and have done so much. We've just barely even scratched the surface. And so we have about our 8 minutes or so, maybe 7. Kathleen's giving me the look. But what I want to do, though, is I do want to offer up you all a little bit of time, and we'll start with Naomi, and we'll just go back down the line, to talk to us a little bit about kind of like your final thoughts. And because, again, this topic is so wide and so broad, and each of you represent some amazing different aspects and avenue of the comprehensive care problem, and that's fantastic. But talk to us a little bit about what your final thoughts are and sort of what you see as the way ahead from your niche and your perspective in this journey.
Thank you for that. So, I think one thing to realize is that the report that we did was, when this annual suicide report came out, those numbers are 2021 numbers. So that's right after us coming out of COVID and all of that. And so we're hoping that that was the reason for the increase, and that it's not true. It's not a trend that's going up, basically.
You don't know.
We
don't
don't
know
know. No. And so we are trying to do, one of the things we do is we work with other veteran service organizations as well. And because it's going to take the whole of the community everywhere for us to try to really understand, okay, is this really, a trend that's going up? What are we doing wrong? What can we, do to help? And really just sound the alarm. And so that's what I'm here doing, and that's why I share my story, is to sound the alarm and let you know that this is what's happening. You know, we don't know what the magic bullet is. We don't. You know, we have s- some evidence in certain areas, but women are not men in a different body. As you mentioned, we are built different. There are various challenges that we have. And one of the things that I spoke about in my story was pregnancy. But one of the things that we don't really speak about too much is menopause. And when I speak menopause, I'm not necessarily speaking about older. I went through menopause, and I don't mind sharing, at 34 years old. And that's because of my military service connected. Thank you very much. But but it's one thing that we don't really talk about, and when you do, it's, oh, older, veterans or geriatric, or no. And so these are all things that factor into that. And so I think the more that we normalize that and talk about it, psychedelic assisted therapy is something that we're very leaning forward on. We're interested in. We have a partnership with that space, and so because we want our veterans to be able to understand, hey, there is something out there that can help you. Let's go for it. We do need to think in unconventional ways, and try to educate our veterans to understand that, hey, this is something that might be able to help you or work for you, work in different communities, work with our provider. By the way, my provider, my primary care provider at DCVA, absolutely love him. He is fantastic, and I will sing his praises forever. But and understand things like the operator, relief fund, and work with that community, because as you mentioned, we are in all of the specialties. We can serve everywhere, and I can understand why why that's an issue. But my final thought is that if you need help, you can go to dav.org. Look for me, nmathis at dav.org. I'm willing to help if you have someone that is in trouble or could be in trouble. There's also a space on the website to share your story, and to help reach other women. And I always say the reason why I tell my story is because if there's just one, then my whole life's work is worth it.
Dorian.
Yeah, I would say my overall goal is to just continue to create trauma-informed communities, trauma-informed organizations, trauma-informed systems. And I think that will help us reach a trauma-informed culture and as a country, and hopefully globally. I would urge people to consider learning and studying about adverse childhood experiences, ACEs, which is something I think we don't talk enough about in healthcare and in wellness. And I think when we start to talk and think about ACEs, we can understand that generational trauma is happening, and things like chronic health or autoimmune disorders won't be so surprising. To me, it's not mind-blowing or baffling that I don't have a thyroid today, given the fact that I have an ACE score of 9. So a lot of our veterans and active duty military members have very high ACE scores, and we're not really talking about that, or we weren't when I retired in 2018. So that's something that I really would hope that as a community and as organizations that we would learn more about.
Thank you. Dr. Vlahos.
So, one of my favorite authors says that the two most powerful words in the English language are "me too." And I think that's such a beautiful thing to think about. I am not military. So, from the outside looking in, what I would say you have is community. You have potentially a ready made community in your brothers and sisters. And that's something I really envy. I think that's wonderful. So much of the work that I do are for people in isolation. And I know that's a threat all the time, that loneliness and that separateness. But if you can get through the Me Too part, that yes, you're not alone, this community that you're building, it is healthcare. It's mental health care, but it is healthcare. And I think it's wonderful.
Thank you. Lisa?
Yeah, I'll keep it short and sweet. So I think the best thing I can say is don't accept that label. Don't accept that diagnosis that you don't like, that you feel lost in, that you're having pain or you just haven't gotten any help with. Don't accept that and keep fighting for that and find somebody on the stage.
Thank you. So we very much look forward to continuing the conversation with you all at the reception following. So if you just will help me thank our panelists for helping ensure that we serve in strength, Lisa Peterson, Dr. Joelle Valajas, Duran Young, and Naomi Mathis. Thank you so very much for your insights.
Wow, that time kind of flew by, and it made me, as I was sitting there listening, I will tell you that as I was in the service and I knew something was wrong with me, I went to my doctor and I told him that, 6 months ago I ran the Marine Corps Marathon and now I can't run a half a mile. 6 months. And I got that lovely pat on the back of my hand and said, well, dear, you're getting older. Don't accept the fact that they just tell you you're getting older. There was, in fact, something wrong, and my body was attacking my own liver. And now I'm on medication for the rest of my life, and hopefully will never need a liver transplant, but I'm just getting older. So without further ado, we're going to take a 15-minute break. There are restrooms out this door and around to your right, and please be back in your chairs at 4:45. Thank you.